this computer.
I think you're recording it now.
Yep, I did. I
Yeah.
just started it. All right. Yeah, go for it.
Let's go back to the slide, my previous slide.
Oh, let me just give you the control.
Yeah.
Okay, I did.
Can't do anything.
Okay.
All right. So I was just telling you that the simple way to treat or fix the aortic aneurysm is to basically take the disease part out and replace that with a tube of Dacron. Now, the one question that always everybody will ask is how fast it grows. And the answer to that question is very simple. It depends on the size of the aortic aneurysm. And the easiest way to remember that is the smaller the diameter, the slower it grows. The bigger the diameter, the faster it grows. And this is the one of the slowest growing aortic aneurysms, unlike the abdominal aortic aneurysm, for example. So if there is an aortic aneurysm that is between 3.5 to 5.5, about 5 centimeter, it's very slow, 0.10 to 0.15 centimeter per year. It's very slow. So but if the diameter goes to about 6 centimeter or more, then the speed of growth is higher. But even then, it is still a slow speed, and that's how it grows. Now, the next question is, what do you do? What do you do when you have an ascending aortic aneurysm? And I think the easiest way I describe this is by rule of five. And I told you there are two numbers you're going to remember, and one first number you have to remember is rule of five. This is my rule. If the aortic aneurysm is 5 centimeter in diameter, or otherwise it grew by 5 millimeter in 5 months time, you need to take that aneurysm out. You need to operate on that aneurysm. Okay. So let's give you an example. You get a patient who has a 4.5 centimeter aneurysm, and he's pretty compliant with his antihypertensive management and all. And you tell him, well, let's do another CT scan with a contrast in about 6 months' time. And you see that that aneurysm has grown to 5 centimeter. That essentially means this rule is applicable. 5 centimeter grew in 5 millimeter in 5 months' time. That's it. This is easy for the patients to understand. This is easy to remember. So the exception to this rule is that if your patient has Marfan's, Ehlers Danlos, or a bicuspid aortic valve, or a Loeys-Dietz aortic valve, then you take 5 back. That means instead of 5 centimeter, you start thinking about replacing it when it is 4.5 centimeter. Very easy to remember. Now, when you, these are rules that are applicable to a compliant patient. So if one way to replace the aortic aneurysm electively, the mortality is 1%. If the patient has the aortic aneurysm which is 5 centimeter in size and is non-compliant to the treatment, that means patient is not taking antihypertensives, beta blockers, and so on and so forth, you add 3 after that 1, their chance of a mortality or a aortic incident is 13%. Remember Hindi में saying है उसका तो 13 बज गया है, you know, that's what you need to remember. So the first number you need to remember is 5. The second number you need to remember is 3. So if the patient is compliant and a 5 centimeter aneurysm or near about 5 centimeter aneurysm, mortality is 1%. If they're non-compliant and doesn't go through surgery, their mortality will be as much as 13%. Now, why do we ask patients to get prophylactic repair? The reason why we ask patients to get prophylactic repair is that these aortas, they become weak in the medial layer. There are 3 layers: intimal, medial, and the adventitial layer. If the tear takes place there, if the tear is taking place in the ascending part of the aorta, whether it is limited to the ascending part or not limited to the ascending part, these two types of them are called Stanford A, or what we call as a type A dissection. These require immediate surgical management. The reason for why they need immediate surgical management is because this tear, when it goes down towards the heart, will cause acute aortic incompetence and the patient will have severe acute heart failure. That's one thing. Second thing is that gradually the blood flow to the brain will start to cut off. You don't want that to happen. And thirdly, as the dissection extends into the coronary artery, they can have a massive myocardial infarction. And as all of you know, door to balloon time of 60 minutes. Imagine what can happen if you do not take this patient to the operating room. So these two types, so whatever happens to the ascending aorta in terms of a dissection, it needs to be operated on, if unless and until there is a contraindication. And so easy to remember, type A dissection, rush to the operating room. Simple. Type B aortic dissection, the reason the usually the tear is after the subclavian artery. That means the dissection starts distal to the subclavian artery, and it usually involves the intercostal vessels and the visceral vessels. Akhilesh is going to talk more about this, but the easy way to remember is that if there's a type A, operate. If there's a type B, you treat with medical management. And the reason why this classification was done historically is that historically we used to 60 years or 80 years ago, we would take all these patients to the operating room, and we realized that the mortality for type B dissection is extremely high. And that's why we decided that instead of having that higher mortality, maybe we can try medical management. So the mortality with the medical management is only 10%, while the mortality with surgical management is much, much higher. But Akhilesh is going to talk more about this. Now, what happens when the dissection takes place? As I told you, you can either get acute aortic incompetence or a coronary incident or a stroke, and you will have cutting off of the blood supply to the most important vital organs. Now, why repair prophylactically? Because you don't want a dissection to take place. You would say, well, why not just, you say that type A dissection you can operate, so why not just operate? Let's just wait till they get dissected. Now, the reason why you want to repair them prophylactic is the rule of third. So I told you five. Now the second number you need to remember is three. A third of the patient will die before diagnosis. That means a third of the patient will not reach hospital. They'll have rupture of their aortic aneurysm, or they'll have a catastrophic arrhythmia, and they will or catastrophic heart failure, and they'll die before they reach the hospital. A third of the patient will die within 24 hours if you do not operate on them, and a third will die within 2 weeks if you don't operate on them. So all of them will be dead by the end of 2 weeks if operative management is not undertaken. So that's the rule of third. Now, the rate of death is usually 1% per hour of waiting. And that's why as soon as the patient comes, we ask them the first question, when did the pain start? And as the every hour you wait, their mortality starts to increase. And as I told you, with an emergency repair, that means you get a patient with type A dissection and you take them for surgery. This is another rule of three you have to remember. A 30% will die after operation. That means within the first 30 days after the operation, 30% will die. That's the operative mortality. A 30% will develop malperfusion and either will need dialysis or something or the other, or will need help from Dr. Jain to come and put stents in the visceral vessels or in the descending aorta. And always remember that any type A dissection, they need to spend 30 days at least in the hospital. So the second rule of three to remember, 30% will die, 30% will develop malposition, and they'll have to stay for 30 days. That is the reason why you want to replace these aortic aneurysms electively where the mortality is just 1%. And even with a non-compliant patient, if and that's why between this 30% when they get this aortic dissection and they have a 30% mortality, if a patient chooses not to get operated and has got a 5 centimeter aneurysm and is non-compliant, their mortality is 13%. You see, so two numbers to remember, 5 and 3. This is my last slide, and that's why I want you to remember the rule of 5. If the aneurysm is 5 centimeter or grows by 5 millimeter in 5 months, operate. A third of the patient will be dead before they arrive. a third will die within 24 hours, and a third will die within the first 2 weeks. And the rule of three that I just told you. Thank you.
Thank you so much, Pramod. We will follow up with the Q&As for this topic once Dr. Akhilesh Jain is done with his topic. So, Akhilesh, I'm going to provide you with the remote control now. Please accept that, and you should be able to move the mouse. And you may have to unmute yourself too. Oh, I think...
I'm unmuted.
Okay, got it.
Can you hear me?
Yep, we can hear you.
Wonderful. Thank you. So this was a nice segue into what I'm going to be talking about. Dr. Bonde covered the ascending part. I'll talk about the descending and the complex aortic aneurysms. These are some of my disclosures. I'm part of a few of the clinical trials. So I'll just go with a case-based approach to this. I'll start off with one case. And the way I'm kind of designed this presentation is once we have managed a patient acutely in the inpatient setting and as they're transitioning to the community, then how do we manage those patients? What are the challenges? And how do we kind of take it from there? So 56-year-old male, smoker, he has a stressful sedentary life. He's otherwise healthy. He's on low dose, let's say low pressure in his case. He has a remote diagnosis of hypertension. He takes his medications sporadically. He exercises occasionally. So it's fairly kind of average, common person who is in general in good health. He experiences sudden onset of severe chest pain. And let's just say he's at home and somebody measures his blood pressure. Blood pressure is 190 by 110. Or let's just say he's in our office in the outpatient setting. And so just some of the diagnoses that come to our mind are it could be acute MI, it could be acute aortic dissection or aortic aneurysm, which is symptomatic or ruptured. Could be a PE as well, chest pain, not exactly, it may not present like this. It could be some, say, GI motility issue also presenting with chest pain or a panic attack. But the bottom line is, how do we manage this patient while he's in the office or in the community setting? Probably most of the time we will end up calling a 911 and getting the patient to the ER. So that's the world that most community the PCPs, the cardiologists live in which on one hand we may be seeing a patient with chest pain, and then as we were just talking a few minutes ago that there's a patient who comes with a testicular mass in one day. Like our practice in the cardiac and the vascular surgery world is very, very focused. To me, a chest pain is probably almost always means aortic dissection because that's what I see all the time. So we definitely have a very skewed perception of what a chest pain may look like. So this patient ends up going to the ER, is evaluated, gets a CT scan, and in this case is known to, we find that there's a type B aortic dissection. So Dr. Bonde mentioned this. I found this video recently on Twitter. I just found it very, very interesting how it depicted it. And I'll just stop the video right here for a moment. And basically, like it was mentioned that there's a weakness in the media layer of the aorta. And what happens is with the shear stress, as there is uncontrolled hypertension, the intima breaks at some point and the blood starts traveling outside the intima in this media layer. And as with every subsequent pulse, the blood is basically dissecting through the aortic wall and weakening the aortic wall. At some point in this, we show that there is just one break. Oftentimes, there are multiple breaks along the way. So how does the malperfusion develop? As you can imagine, let's just say there is a small blood vessel coming off on the sides here. That the blood flow to that vessel will get occluded. So as this dissection propagates from the descending thoracic aorta down into abdominal aorta, the patients would end up losing their blood supply to their visceral arteries, the renal arteries, to the lower extremities. So that's what the malperfusion syndrome may look like. The patient has tearing chest pain, followed by either paralysis, or they go into renal failure or acute mesenteric ischemia. As this dissection goes back and is kind of, say, ascending aortic dissection, these patients would have a acute myocardial infarction or a stroke. So a lot of these patients present with a stroke. So that's where uh, uncontrolled hypertension, when we talk about in the community setting, how it impacts what can happen to these patients. Of course, there's another component to it, is the connectivity tissue disorders, and there are certain known connectivity tissue disorders that we are aware of, but I'm sure there are many more that we are yet to discover are the predispositions that lead to these patients developing aortic dissection. So what next? What happens for this patient? Like in this, we'll go to the next animation. So we already talked about the ascending and the descending aortic dissection and the manifestations. So what happens to this patient? As we just go in this animation and we see the tear in the aorta, how do you manage this? Basically, it's a stent graft repair. And what is happening here is, as you place that stent graft, let me just get it to the right place. So as you place the stent graft, you have obliterated the flow in that false lumen, and the blood is now going just in the true lumen, or the main intended lumen of the artery. And then this portion of the artery just starts, the aneurysm starts collapsing and just remodels itself. So like back in the day, like Dr. Bonde had mentioned, that the open surgical repair of type B dissection was extremely morbid. But in last decade or so, with the institution of the endovascular therapy, the the endovascular repair has definitely revolutionized this paradigm. And for a lot of these type B aortic dissections, we repair these endovascularly with stent grafts. So the big question is, what next? The patient is treated that time. The dissection goes all the way down into the visceral arteries. For most part, our goal is to address the entry tear. That's where the entry of the blood started. So we do not treat the entire aorta from the descending all the way down to the iliacs. And generally, that's where the dissection ends, into the iliac arteries. So there is some residual disease aorta. So what is next? What do we need to do as this patient goes back home, goes back to their cardiologist or family practice or primary care? Generally, this is the place where these patients transition back home. That we have repaired the stent graft, we have repaired the dissection with the stent graft, but the aorta is not remodeled. There is still an aneurysm left, which is going to take many months to remodel. So that's what we need to realize, that the pathology has been kind of temporized and stabilized, but it is not completely treated. The treatment process is, it is the beginning of the treatment process. So what needs to happen? This is the first and the foremost thing, which is probably the most difficult part of these patients, is control of their hypertension, which is, I would say, in all practical purposes, a root cause. Because we cannot control our genetics, but we can certainly control our hypertension. So I would say it's a modifiable, very important cause that we can address. We want to rule out connectivity disorder. So that's again a multidisciplinary approach. That's the easy part on part of our specialists. When we see these patients, we see some high risk factors, we have them go to see a geneticist, and we rule out the connectivity disorders. Third part is the monitor the complication. So we serially image these patients. Typically, we'll have the CT scan and MRIs done for these patients every so often. And again, any mature aortic center, any mature aortic program would have protocols in place, which again, we can monitor these patients, we give them follow-up appointments and follow them up. The last part is education. Oftentimes these patients are just not aware what is going on. To them, oftentimes it may mean, oh, I got the stent graft placed, my aortic dissection is treated, and I'm back to my usual activity. But that's not the case. It is very, very important. So that's the reason why I highlighted the hypertension and the education piece of it, which we find is the hardest thing to do. That is the heavy lift is actually happening out in the community, out in the outside the inpatient setting. That's where the heavy lift is happening. So what are the blood pressure goals? I would say the blood pressure goals, almost you want to talk about it like the way we have changed our philosophy in the management of diabetes, that we want a long sustained control of blood sugar as opposed to being very, very aggressive with it. So I call it the patient centered blood pressure management. We call it generally low normal and norm. You want to have a normotensive. We don't need to necessarily have these patients hypotensive. I always advise these patients to get some wearable blood pressure monitoring system. That way they can monitor their blood pressure multiple times a day without much intrusion in their lifestyle. And because these patients typically are young, healthy folks who want to be active, and if their lifestyle is very much disrupted, then it's hard for them to comply with all the instructions and the advice that we give them. I always ask them to maintain a BP log, and that's very easy. Again, with the modern wearable blood pressure cuffs, they just carry a wristwatch. They are monitoring their blood pressure, and it just goes by Wi-Fi in an Excel sheet, which is very, very easy. Education of the patient and the family, and I've seen a tremendous improvement in their compliance if we bring their family and educate to them as to what's going on, what's the pathology, why is this blood pressure control very, very important for these patients. And again, sustain long-term blood pressure control. I'll give you an example. I took care of a professional athlete 3 years ago. He had type B aortic dissection, and as we controlled his blood pressure, he was kind of experiencing in the initial days a kind of postural hypotension, and his just compliance was becoming harder. And that's where we intervened, and we said, well, our goal is that, we want you to be just in a good control. We are not looking for like 110 systolic blood pressure. What we are looking for is if you can maintain a 130 blood pressure most of the time. And when you're playing, doing something, if it occasionally goes to 160s, that's okay. You want your body physiological mechanisms to be intact so that you're not feeling a postural hypotension, which is a very important part of it. And that's where like the diabetes management has shifted, and that's where I feel that the blood pressure management of these patients should shift, so that in long run their blood pressure is very well controlled. And that's where the role of the primary care out in the community is also very, very helpful. So what next? Close communication with the vascular, the cardiac surgeon is extremely important, so that these patients are able to go back to their physician and get the follow-up imaging done. Oftentimes, these patients may again feel that, okay, I got the stent graft done, and it's not a one and done deal. What we call is once aortic dissection is always aortic dissection. It's a lifelong pathology. And we basically just explain it to them. We are going to be friends for life, and we'll be seeing you every few months and for next 15, 20, 30 years. Surveillance techniques, basically what we're looking for, we generally try to do a CT angiogram, which is a very good modality to find out what the stent graft is doing. Is there a good remodeling of the aorta happening? And is there any aneurysmal degeneration developing? Of course, it's a radiation-based technique, so we want to avoid that. So once the patient is stabilized a bit, then we switch over to MR angiograms. And sometimes once the patients are far enough out, few years, 3-4 years out, I would switch them to non-contrast based CAT scan. So even though it would not opacify the lumen, but at least you know what the aortic diameter is doing. In conjunction with the clinical examination, you get a fairly good idea of how things are going. So I'll just switch over to the complex aortic aneurysms, and it's again a very brief presentation. I'm keeping it basic and not going into the details for like from the vascular, the cardiac perspective. So when we look at the aortic aneurysms, how do we repair them? Firstly, when we look at the indications for the repair, it's the rules of five very much applies. In general, in women, we say 5 centimeter diameter aneurysm, or if it is symptomatic, or if it is growing, you can use the same thing, more than 5 millimeter in 5 months. I think that's a very good way of remembering it. In men, it is 5.5 centimeter diameter aneurysm that we treat, and or if it is rapidly growing, again the same rules apply on the infrarenal or the other complex aortic aneurysms. The traditional way has been the open aortic surgery. You do a midline laparotomy, basically excise this disease segment and replace it by the same Dacron graft that Dr. Bonde mentioned. However, in 1990s, this concept of endovascular aneurysm repair was developed, which is now the gold standard. I wouldn't say the gold standard, but the most commonly used technique for the infrarenal aneurysms. More than 98% of the patients with standard infrarenal aneurysms are treated by the endovascular aneurysm repair. And what we do, we are basically leaving this aneurysm sac in place. We make small punctures in bilateral groins like the cardiac cath, and we place these stent grafts, which is again the same material. It is a similar material, the woven Dacron material, which is mounted on a metal stent, and it's a flexible stent, and it seals off in the healthy aorta proximally and the iliac arteries distally, and cuts off the blood flow to this aneurysm sac. So basically, it excludes it from the circulation, and that's how we treat the aneurysm. And when the aneurysms are much more extensive, involving the celiac arteries and the mesenteric arteries, or even extending into the thoracoabdominal aorta, then comes the multi-branch stent graft, in which they have small branches that we can place, and then they go into various arteries, and that's basically a completely personalized aortic care. These are the stent grafts which are designed specifically to a patient's anatomy, and we use them to treat the aneurysm in the same way. And typically, this is what these patients go home with: a small incision in the groin, on both the groins, plus minus a small incision in the arm, and that's it. And they go home, and generally, it's 24 to 48 hours of stay, and they are able to transition back to home. So, who do we screen? If we look at the Society for Vascular Surgery guidelines, generally, and they are slightly different from the US Preventive Task Force guidelines. And I would not go into those details, but the bottom line is that any men or women with the age of 65 to 75 with a history of smoking or family history of AAA. So, anybody with a smoking or family history of AAA more than 65 years of age, they should be screened for abdominal aortic aneurysm. Now, over the age of 75, if there is a history of smoking, or then they should also be screened. Now, this is not part of the US Preventive Task Force guideline, but when we look at the SVS guidelines, this is what their latest guidelines are. And how do you screen? And the high risk groups, when we look at generally anybody with a strong family history of aneurysms, if we see that there are multiple family members uh, who have aortic aneurysms, those are high risk groups. Generally, the way we look at it is, if somebody had a ruptured aortic aneurysm at, say, 60 years of age, we ask their children to be screened, say, 5 to 10 years younger than that. And that's more in the clinical context. It's not there is a specific guideline. I don't know if Dr. Bonde would agree with that or not, but we all use somewhat similar guidelines. I've heard from most people using it. If there's somebody has a known connective tissue disorders, we should have high index of suspicion, and we should screen these patients. And when do we send these patients to the specialist? There are two ways of looking at it. Depending on what kind of practice setting we are in, if we have adequate resources, a good place where we can get the screening ultrasound done, then it's perfectly fine to keep on screening these patients until they are getting close to about 5 centimeter diameter. Generally, I would say when the aneurysm grows more than 4 centimeter in diameter, it's time to send it to the specialist so that they can keep a closer eye on these patients, look at other risk factors, start risk stratifying them, and repair them electively before it goes on to rupture. Sometimes, if the practice is very busy or we are not able to get a good screening ultrasounds done, then it's perfectly fine. If you find an aneurysm at, say, 3 centimeter in diameter, to send to the specialist, because that's what we do all the time. We monitor these patients sometimes for decades with a small aneurysm to make sure that they are not enlarging, and if they're enlarging, we take care of it before they go on to rupture. Generally, ultrasound of the abdomen is a good modality. It's a non-radiation based modality. We can also use CT scan without contrast. For screening, we do not need a CT angiogram. A CT scan without contrast is perfectly fine. Or if they had a CT scan done for something else, if we just pull up the images and look it up, we kind of know that they do or do not have aneurysm. For thoracic aorta, we got to have a CT scan. The ultrasound is not a modality that can pick up the thoracic aortic aneurysm. The echocardiogram can pick ascending aortic aneurysms, but not the descending thoracic. So I would say if we are looking for a particular reason that we want to screen the descending thoracic aorta, then I would say CT scan is the only modality, or perhaps MR angiogram, which is a little bit more extensive. So the patient undergoes the endovascular repair. Again, it's a lifelong follow-up with us. We always monitor these patients year after year after year to make sure they do not have endoleaks. So that brings us to what is an endoleak. When we look at this slide, basically we have sealed out the aneurysm using all these stents. However, what can happen is that you can have blood going by the side of the stent for some reason. Either the stent graft migrates or the aorta here dilates. We have blood going into the aneurysm, or there is a leakage between these components. So that's what we call as an endoleak. It's a leakage of the blood inside the aneurysm. The thing to remember is a type 2 endoleak, which is a very, very benign endoleak, which is basically backfilling of the aneurysm sac from the intercostal arteries or the lumbar arteries and things like that. Basically, a branch vessel. It's a low pressure endoleak. It does not typically cause a rupture of the aneurysm, and we keep an eye on it. The reason I discuss this endoleaks is that oftentimes what happens is these patients have had their stent graft repair done. They get a CT scan done for some reason, and the patient's radiology read is, oh, there's a type 2 endoleak in the aneurysm sac, and that becomes a very worrying feature to the patient and to someone who is not familiar with this terminology. So endoleak does not necessarily mean that there's a leakage of the aneurysm. It just means that there is some blood flow outside the stent graft into the aneurysm. And if it is type 2 endoleak, it is a perfectly benign condition that is physiologically present, and we leave it alone for most of the time. If there is type 1 endoleak, which is attachment site, or a type 3 endoleak, which is between the components, then that's a high pressure endoleak, and we need to intervene on those patients. So just something to remember, high risk endoleaks are type 1 or 3, or aneurysm sac expansion. Those are the features. If we hear that on a radiology report, then that's the time when it should kind of raise a red flag, and at least merits a phone call to the vascular surgeon to ensure that this is something being observed and watched out for. Type 2 endoleak you can ignore because somebody is definitely keeping an eye on it, and especially if there is a stable aneurysm sac. And I will stop right there. I bring up this slide as surgery is only part of the story. Is we call ourselves vascular surgeons, but when we look at our practice patterns, probably 60% of my practice, and that is true for almost all the vascular surgeons, is vascular medicine, management of the hypertension, management of their statins and the lipids, counseling about how to take care of the lifestyle modification, the smoking cessation, things like that. Probably 40% of what we do in our practice is surgery. So that's something which is, I just thought that it's important to emphasize. And I will stop at this point. Thank you.
Thanks, Akhilesh. I'm going to take the control from you.
Yes, please.
Okay. All right. So we have some questions. One is Dr. Chunamala. What is the first thing to do when patient comes into ED with crushing chest pain to differentiate dissection from other causes to save time? I think this will be for Akhilesh.
Or Dr. Bonde?
Or Dr. Bonde.
We can go either way. Yeah.
Yeah. I think if there's a patient that comes with a crushing chest pain, the most cost-effective way of uh, making a diagnosis, if there are no EKG changes, I think doing a EKG is the most basic stuff. Because if it is acute MI, you would know. If it is a coronary syndrome, you would know. If that is not the case, you straight away put the patient into a CT scan and make sure that you have a CT scan done for the patient. Whether you choose to do a non-contrast or contrast, it doesn't really matter, because it will pick up something or the other anyway. But most ERs will basically do a CTA for this type of patient. If the index of suspicion is higher for aortic dissection, I still believe that clinical triage and clinical decision making plays the role, because you have to realize there's another question that was asked. I was just reading it. What is the incident of aortic aneurysms? And you have to realize that the incidence of aortic aneurysm differs in the males and females. In the females, it's about 1 to 3 aortic aneurysms per 100,000 patients per year. You can imagine how small that number is in the United States. For the male patient, it ranges from 5 to 10 patients per 100,000 per year. Let me translate that for you. For a $350 million population, that is about 3,500. Okay, about 35,000 patients per year in across United States who will have an ascending aortic aneurysm or dissection or anything together. 35,000. You see. How do we know this? Because if you look at people who practice ascending aortic surgery, there's only 1 or 2 people at every center. So these are smaller numbers, you see. And so clinical history taking is still very important. The nature of pain and all those classical things. It is a pain that is really, really classic. Tearing time, going to the back between the shoulder blades, never felt it before, those kind of things. But
Uh,
CTA will be the way to go for it.
I would agree with that. I would say that getting a good history part, ruling out acute coronary syndrome, which is probably 10 to 15 times or maybe 20 times commoner than aortic dissection. And again, for us, a chest pain is very, very common. We see aortic dissection all the time. But when we are talking from the ER perspective, I think the acute coronary syndrome is much, much more common pathophysiology. And that's the reason I started off with that case presentation. The other thing I would say is that doing a CT angiogram, and if you're doing a CT angiogram of the chest, I think it's totally worthwhile adding abdomen and pelvis to it, because if there is indeed aortic dissection, it just is immensely helpful that we have the imaging of the abdomen and pelvis. That helps us with the treatment planning as the paradigms of how we are managing this aortic dissection is changing. I think it helps us tremendously. So if we have enough index of suspicion to suspect a dissection, it's worthwhile ordering a CTA of chest, abdomen, and pelvis. Uh,
Another way to look at it, what Akhilesh just said, is imagine amongst all the differential diagnoses, which are the most dangerous and which, if you miss, will cause the most damage to the patient. Type A dissection and acute myocardial infarction. If you don't fix it in time, you're going to lose that opportunity. Pulmonary embolism, although everybody who comes into any American hospital or any American ER will get a CTPA. I think and all you do is give the patient heparin. It means there are some basic stuff like look at their saturations, look at their respiratory rate, and so on and so forth. But I still see so many patients. And I used to get so many calls before I actually decided to set up a pulmonary embolism interest group. Because all these segmental PEs that you would get, and they would call saying that, oh, we need to call a CT surgeon to fix them. No CT surgeon can take away any segmental PEs, not even in the main lobar arteries. Only in the main artery is the one that is surgically treatable. Rest of them basically need endovascular or other treatment. So there was a
in
question
fact,
again, I think.
yes, I would agree. In fact, even for that PE perspective, we use so much of endovascular therapy these days. There is such a big revolution. We have the thrombolytic therapy, we have the clot reaver devices, we have suction thrombectomy devices. And as part of a PE response team at our institution, we take care of probably good 7 to 10 PEs a month, and we treat them endovascularly these days, even the saddle pulmonary embolism. I will kind of share an example of a patient, one of the hardest patients of aortic aneurysm that I treated. And that's classic what you mentioned about how do you differentiate that patient with acute crushing chest pain. This patient had uh, basically low back pain, severe crushing low back pain, hypotensive. He had changes on the EKG, was diagnosed with acute MI at a urgent care center, and obviously absolutely right thing to do was loaded up with Brilinta and transferred to the cath lab. He was taken to cath lab like with the door to balloon time and all those things. And as they were looking through everything, it was like something is not right, does not make sense. And that patient's cath turned out to be negative. He had already been loaded and he was about to be coded at that time. And they pulled down the catheter, did shot an angiogram. He actually had a ruptured thoracoabdominal aortic aneurysm. Uh, so I ended up repairing that patient fully loaded on Brilinta. I've never seen such bad bleeding in my life before that or after that. Yes, that patient survived. He's 40 years out, but it's just, yes, it's a very difficult sometimes diagnosis to make in the ER setting. So yes, kudos to the folks who are on those lines.
Wow, that's pretty impressive, Akhilesh. Well, the next question. This is from Dr. I'm sorry, Sujata Prasad. I have a patient with Marfan syndrome. Should I be getting CT angio or MR angio on a regular basis rather than ultrasound? How frequently should I screen?
So I can take this question and then Akhilesh can add to this. So Marfan's syndrome, as you know, is not just the aortic disease, but also disease that is related to their aortic root and the aortic valve, which is what will basically bring them to the attention before the aortic aneurysm. And so the best way currently should be to do a baseline MR angio, which will give you all the information that you need. If you know how are the sinuses, how the aortic root looks like, and so on and so forth. And MR angio is pretty stable, pretty safe to do as long as the patient is not claustrophobic, for example. And it should probably do the, if you do a proper MRA, it will probably take all the neck arteries to the pelvic, or to the groin arteries. You'll get a good picture of that. Um, I think I would probably not follow the patient with an ultrasound if they have a Marfan syndrome. I would probably go for a more advanced imaging modality, and include them in more education in terms of how to kind of report to you whenever they see a change in their symptomatology.
Yeah, I would agree with that. I think ultrasound is non-specific. It is good for screening, but certainly for somebody who's such a high-risk patient, I would agree with the cross-sectional imaging, either MR angiogram or CT angiogram, to establish a baseline. And if indeed there is some pathology identified, then we should certainly have that patient plugged in with a specialist at a aortic center, at some specialist, either a cardiac surgeon or a vascular surgeon, so that that patient can be monitored on a close basis. Now, if the MR angiogram turns out to be negative, then that's a different story. Then I would say probably in few years again, or at least educate the patient. But if there is any pathology noted, then they should be plugged in with someone.
I think the way I usually tell the patients and or explain to the patient is that if you have your first examination normal, then we can probably do your next examination in about 3 years time or so. But if your first examination is abnormal, you should have your examination done every every birthday. On every birthday, you should have an imaging. That's your ticket to the next year. If you don't get the imaging, there's something, because Marfan's is such a disease where you're sure to intervene on them during the second, third, fourth decade. By the time they reach mid third decade, you have already probably intervened on them or planning to intervene on them. And so it's important to have them be followed with that. Now, if something changes within that 3 years, either you say you see them developing more, skeletal features or whatever, or other complications of Marfan's, that should trigger a earlier imaging, even if they're asymptomatic.
Okay. Thank you for that, Dr. Bonde. You have another question from Dr. Shekhar Chirnomala. How often you see bicuspid aortic valve causing aortic aneurysm? Do we need to monitor them with imaging annually?
That's a very good question, and I think this is underappreciated in the context. So I told you that 5 to 10 patients per 100,000 per year is the incidence of aortic aneurysm. Guess how much is the incidence of bicuspid aortic valve? Bicuspid aortic valves affects at least 1 to 2% of the population, and so it's far higher incidence compared to what you would see with aortic aneurysms alone. Now, bicuspid aortic valves are most of the time the diagnosis is unknown till they present with something, and mostly it's in the fourth or fifth decade, or most of the time fifth or sixth decade is when they present. If the diagnosis is already known on an echocardiogram, I would say, and if the first examination is negative, it is safer to just follow them with an echocardiogram, because usually these patients they get this sinotubular junction, that is the bottom of the aorta dilating, which can be easily picked up on a transthoracic echocardiogram. You don't need to do a transesophageal echocardiogram for these patients. They can be easily picked up. And many of these patients, I usually tend to preserve their valves as long as they can, as long as I can, so that they don't get a prosthetic valve disease, because any prosthesis that you put in also gives a prosthetic valve disease to the patient, um, anticoagulation, thrombosis, and all, and bacterial endocarditis and so on. So I think that's what I would do in terms of a bicuspid aortic valve. All the bicuspid aortic valves, they will lead to an ascending aortic dilatation, and if you have to replace or repair a bicuspid aortic valve, you must replace the ascending aorta. You do not really need to replace the hemiarch or the arch or the rest of the aorta. The most of the disease is limited to the ascending aorta. There has been a lot of controversy in back and forth, but we do know that they have an aortopathy that affects their aorta, and so that's important to do that, to monitor them with an echocardiogram. Naturally, if they have a aortic aneurysm that is 4.5 centimeters, then I would definitely do a cross-sectional imaging, as Akhilesh mentions. And the reason for doing that is that there is a difference, and there's a degree of sensitivity between different types of CT scans year to year to year. So, and you need to have a more sensitive investigation to be able to say that yes, this aneurysm is growing, or no, this aneurysm is not growing. Because if you see one of the slides that I showed you, aortic aneurysms, they grow very slowly. They grow very slowly. They grow at the rate of 1 millimeter to few millimeters per year. So they're very slow growing, and so your imaging and your ability to compare one imaging to the another one can make a difference of at least 3 or 4 millimeter, for example. And so that's important, because these are also very young, productive people, you know in their mid 50s or something, where they're very productive, and you tell them you're going to do a surgery for them. They need to arrange things around to make their surgery happen, you see. And so it's important for them to have a good cross-sectional imaging to be able to compare. So yes, they must have a surveillance, but in the beginning, you can just do an echocardiogram. Once they reach certain size, they should have a cross-sectional imaging.
That's a very good point. And like you mentioned that, yeah, one imaging modality does not necessarily translate into the same diameter on the other imaging modality. We see it so often, it does generate a significant amount of panic that, oh, on the ultrasound, the aneurysm measured 4 centimeter, and we got a CAT scan for some reason, the aneurysm measures 4.5 centimeter. So it has probably grown by 3 or 5 millimeters in last 3 months. That's not necessarily true. It is just that every imaging modality measures slightly different. So at the same time, two imaging modalities may vary by a few millimeters. Absolutely. That's a very important point.
And that's a good point. You have to realize that radiograph or MRI are basically non-magnifying imaging. That means they do not really magnifying the organ that is being sectioned and when they image. Echocardiogram, on the other hand, is an ultrasound, and you can get a little bit of magnification, or it is very operator dependent, where the way you measure the aorta in terms of where the probe is sitting and where you took the image can make a lot of difference. While on a CT scan or MRI scan, you can actually visualize where exactly you are taking the cut, and you can standardize it by saying at the mid portion or at the midpoint of the pulmonary artery is where I'm going to measure the transverse diameter of the aorta. You may or may not be able to do that in an echocardiogram, and so your echocardiogram may not give you a good understanding of that size of the aorta.
Cool. I think we have 4 more questions,
Yeah.
so we can kind of browse through this. It's 8:10, so we will try
Sure.
to wrap it up soon. So, what are the screening guidelines for abdominal aortic aneurysms?
So the simple way I would say is anybody over 65 years of age with a family history of aortic aneurysms or a history of smoking should be screened for aortic aneurysms. That's a very simple, easy way to remember the screening guideline. There's also that if once people reach beyond the age of 75, then any smoker who has a history of smoking in past, and we talk about smoking, basically if somebody has smoked more than 100 cigarettes in their lifetime. So if anybody has attempted to smoke cigarettes, that's basically that counts towards their smoking history. So anybody over 65, I would say, should be screened for abdominal aortic aneurysm if they are smokers or family history.
All right, thank you. The next question is again for you, Dr. Jain.
Yeah.
Medical therapy with antihypertensive or statin treatment is not shown to be beneficial
Yeah.
in human study. Hard to
Yeah, I
believe.
got it.
But
Yes. Yeah.
what is your take on this?
So you're right. You're right about the fact that there is no hard data to suggest that if ACE inhibitors or beta blockers have, they do not, they prevent the development or the growth of the aortic aneurysm. But when we talk about those, we are talking about a very specific medications. But in general, hypertension, especially uncontrolled hypertension, has been associated with growth of the aortic aneurysms. And the same thing is the statin therapy when we talk about it. So statins per se are not shown to, even though there is some data, some debate about it, but when we look at all the data, statins per se do not stop the growth of the aortic aneurysms. However, why is it important? And Dr. Katichia also asked another question: how critical is the role of LDL management and prevention of aortic aneurysms? So not directly, but what I would say is that when we look at the aortic aneurysms, they are known to be atherosclerotic degenerative process. So it's atherosclerosis, which is weakening the artery. Let's just kind of put it simply, and that is causing the degeneration. Of course, there could be connectivity disorder and things like that. So from that perspective, if we are controlling their root cause, atherosclerosis, we are controlling their LDL, managing with them with statins, they're controlling their blood pressure, decreasing their smoking history, and all those things. I think that does help these patients. When we just look at the patient with aortic aneurysms, it's like so commonly we see that they are all smokers. They're so often they are smokers. So it's a degenerative process. We are losing the media, the elasticity, the elastin fibers, and there are so much things happening in the aortic wall. So it's not a direct, but directly, definitely indirect effect. What do you say, Dr. Bonde?
I think you covered everything. I think at the end of the day, medicine is 90% art and 10% science. And the way to prove that is that, we keep practicing something for thousands of years, not realizing that it's totally wrong. So I think it's one of those things that, what makes sense when the beta blockers came in the market. We were told that, hey, listen, look at these large animals. If you look at the larger the animal, lower is their heart rate and longer they survive. Shorter the animal, smaller the animal, like hummingbird, higher the heart rates, shorter their lifespan. So beta blockers make sense, you see. That's a very oversimplification of the things. And I think that's where, usually you can get into trouble. But I think on the whole, you know, if you look at just the physical laws of Laplace's, for example, which basically tells you that the more the wall tension, the more it will expand. It does make a philosophical and logical sense to have the patients on beta blockers and lower their blood pressure. Even if if they're not likely to grow the aneurysm, but at least they would not get complication associated with their uncontrolled hypertension. And so I think there's still a role for those. I think statins, I'm not so sure if statin would directly affect any of these, aneurysm therapies, because statins has got a different way of working through. And I think, I wouldn't, say that because there are reports like this, we shouldn't treat hypertension or we shouldn't treat, their high cholesterol. We must treat them, but we need to also look at a certain group of patients who have a certain different types of diseases. And as I mentioned, aortic aneurysms are not that common. They're rare. They're a rare group. It's just that in this audience today, of how many people? In 15 people, there are two people who are specialized in aortic diseases. So it's a little bit odd that we're talking more about aortic, but in common, they're rare diseases. And so the principles of treating hypertension should still remain the same. That's what I feel.
I agree. I think the blood pressure control and the lipid control, the benefits of it far outweighs, like, in so many more different ways. It's more helpful just beyond the aortic aneurysm. That's a very small part of it.
Uh, Question from Dr. Ramurthy Chirmamula. How often you still need to do open abdominal aortic aneurysm repair? Impending
Yes.
rupture.
Yeah.
Yeah.
So, when we look at the national trend, just nationally, the open repair of aortic aneurysms has gone down tremendously. It's a completely downward going slope. And, when we look at, uh, like, it has gone down to maybe 5% of what we used to do. But I would say that the rates of open aneurysm repair are going up again slowly. And the reason for that is that, the technology, even though it has been around here for almost 10 to 15 years, it is still not mature for the endovascular therapy. As we kind of expand the horizons of dealing with aneurysms which are involving the visceral aorta, our techniques have gotten sophisticated, our life expectancy for patients have gone up. We do encounter some challenges with the endovascular repair. So there are lots of reasons, anatomical reasons, why we do the open surgical repair. If the patients have very diseased iliac arteries, we just do not have a highway through which we can deliver the stent graft, then the only way to repair it is open surgical repair. So any busy aortic center still does fairly good number of open surgical repairs of aortic aneurysms, but it's not like the norm. It is more depending on case to case basis. So that's, and for most part, if a patient has connectivity disorder, I would say it is the gold standard. The open repair is the gold standard, regardless of where it is. Besides the case reports here and there, we almost always do open surgical repair of those aneurysms.
Perfect. I think that concludes all the question. I'm just going to open the floor for everybody. Okay, I am not able to do that. All right. Sounds good. So this was a great talk, Akhilesh and Pramod. Thank you so much for doing this. I want to thank you on behalf of all CAPI executive committee that you took your time out of your busy schedule to kind of answer all the great questions. This is going to go on our website. The participation was good, but in the sense that we are also leaving a digital footprint where people can refer to this on days to come. For anybody who wants to refer their patients to Dr. Akhilesh Jain or Dr. Pramod Bonde, Dr. Bonde practices at Yale School of Medicine, and Dr. Akhilesh is chair of Hartford Healthcare. So it's very easy to reach them out. You just Google their name and probably they're the first people to come on there. any questions, if you have any follow-up questions, you can feel free to just email me. It's vittalsr@gmail.com, and then I can forward it to Dr. Akhilesh or Dr. Bonde, and then we can get you guys connected. Having said this, thank you so much, everybody, for joining this, and I will conclude this call. Thank you so much.